Thanks. So this is just a brief overview of the agenda. We will have a number of presentations first, and then reflections from the floor, and a few colleagues have actually prepared remarks as well. And we'll introduce the agenda as we go along in further detail. Next slide, please. So as you know, this is really the first in a series of meetings. You can even go to the next slide. With other sessions following on structural barriers, monitoring, evaluation, and financing of key population responses. But this very first meeting we have really dedicated to building a foundation for scaled key population programs. This community of practice, as you know, is one approach that the Global Prevention Coalition engages in collaboration with the South-to-South Learning Network to operationalize the new global AIDS strategy, which has a strong focus, as you know, on key populations. There are several global targets relative to key populations now. 95% of key populations using person-centered combination prevention options. 95 targets for HIV treatment, not only in general, but specifically for each of the defined and agreed key populations. We have 10 targets on social enablers, including to ensure that less than 10% of key populations experience stigma, discrimination, and violence. We have a target on 80% of prevention services being community-led. And what all these targets require in common is a scaled response. And this is what today's session is really about. How can we create trusted and scaled community platforms through which these targets can actually be achieved together? We often think about scale as an economic or service delivery principle, but it's really essential for all elements of the response, and also for equity. It's about whether a sex worker in a remote Southern African town has a peer outreach worker whom she can trust in matters in relation to services or in matters relating to the case of violence, or a young gay man in any suburb of a mid-sized city around the world who wants to access different prevention choices. We can only achieve the ability to have services and trusted access for key populations available through a scaled presence. Scaled and trusted key population responses cannot be achieved by a single constituency, and this is why this community of practice really wants to bring together players from government, implementers, and most importantly also communities to work together towards achieving global targets. This is in particular because no constituency can really achieve this progress against the global targets in terms of scaled responses on their own. So today, as mentioned, we'll hear presentations first, including some concepts on trusted access platforms, but more specifically also country examples, good practices. In the morning, we've heard from Kenya. In the same session, now we'll hear from Zimbabwe, and the second time from Ukraine on experience with scaled programs. We'll hear important community perspectives from the African Sex Worker Alliance and from the ECHA region. So without further delay, I'd actually like to introduce the first speaker of this webinar, who is Parinita Bhattacharjee, an experienced colleague from the South-to-South Learning Network, having previously worked in India and Kenya on key population programs. Over to you, Parinita.
Thank you so much, Clemens. Good morning, good afternoon, and possibly good evening to some people. I'm going to share about building a strong foundation for a scaled and effective HIV response with key populations, with special emphasis on building a trusted access platform. Next slide, please. Key Populations Trusted Access Platform. It is a guidance document available in the GPC website. I will urge you to check it out. The focus of the Key Population Trusted Access Platform document is to share the principles of building a solid foundation for key population service provision. A trusted access platform is the foundation on which effective key population programs are built, and a range of community and facility-based interventions and services are provided. A trusted access platform supports all key population, both as individual members and communities, addressing common needs regardless of HIV status or other specific health requirements. It is also a way of working with key population communities to establish trust and improve access to services, involving close collaboration on program design, implementation, monitoring, and on addressing critical enablers. Trusted access platform may be implemented by KP-led organizations, other community-led organizations, non-government organizations, or civil society organizations. It can be done in collaboration or support from government and donors, but they derive their effectiveness from the engagement and participation of active key populations. Access platforms may be physical or virtual or combination of the two, but they will eventually entail contact between program recipients and program providers. Access platform, the trusted access platform at local level, are the building blocks for a scaled up national program for key populations. Next slide, please. Key population implementation tools, you may have seen many of these, the sex workers implementations tool, the MSM implementation tool, the transit, NIGUIT. These are the primary references for TAP guidance document, and they should be consulted for more details on designing effective key population programs. They are also available in the GPC website, and you should look at those guidelines. This trusted access platform guidance does not go into details about specific package of services, which are included in these implementation tools and also WHO guidance. Rather, this document focuses on the principles of building a foundation for key population service provision, one that enjoys high level of trust and participation with and by key populations in community and clinic settings. Next slide, please. The document has 12 chapters. It's split into two parts. The first part focuses on intervention design for impact, and the second part focuses on management of scale and coverage. The document also has 4 annexures which provide practical examples. The unique feature of the document is that each chapter ends with a summary of what is needed and what needs to be budgeted. The budget guidance provided in this document helps in understanding general resource need for each activity. Hence, this is a useful document also for proposal writing. Next slide, please. A trusted access platform has several advantages over narrowly designed programs. Experience has shown that a single focus vertical services, whether for condoms, HIV testing, PrEP, or other services, often struggle to reach many key populations for those, especially those who are most vulnerable, resulting in low service uptake, use, retention, or impact of the program. Additionally, if these vertical services are able to reach individuals, there is a missed opportunity for a more comprehensive encounter. As a platform, coordinated community and facility-based efforts combine to build trust, reach key populations in high numbers, and encourage their uptake and retention and active participation in programs. Next slide, please. So what are the main elements of a trusted access platform, especially in relation to developing an intervention design for impact? Trusted access platform are built in close proximity to key population communities, and they maintain a continuous presence in places, whether it's physical or virtual, where these communities meet. This means continuous consultation and engagement with key populations to understand their needs and preferences. This continuous engagement is most of the time facilitated by peer outreach workers who are engaged by the program based on their knowledge of the key locations and their rapport with the peers. In addition, safe spaces and structural interventions are critical enablers. Safe spaces enhance outreach by providing security and building community trust. These spaces need to be welcoming, secure, and provide opportunities for rest, networking, meetings, and also clinical services where feasible. Safe spaces like drop-in center, as they are called in many places, provide simple amenities that attract key populations and facilitate community cohesion and networking. Structural interventions make the local environment safer for key populations and reduce barriers to prevention services and especially utilization of the services. Addressing structural issues build trust, remove or mitigate barriers to prevention and service access, and improve condition for key population. A range of structural interventions, including addressing unfavorable legislation and policy, violence, stigma and discrimination that they experience, community empowerment and safety and security have been effectively implemented by key population communities with program support. Next slide, please. Other elements include strengthening outreach. As mentioned earlier, peer outreach workers are a critical part of community outreach. So programs should remember to budget for sufficient number of peer outreach workers and peer outreach supervisors based on the population sizes. We should also budget for the remuneration, travel and phone reimbursement, initial training, refresher training wherever needed. Peer education based in key location is a starting point for microplanning, which empowers key populations to lead outreach efforts, especially because it builds on the knowledge that peer outreach workers have of the communities and to share their experiences with other key populations who live, work, or meet there. Microplanning helps their experiences with other key populations and then also helps to understand individual needs of key populations in their cohort and plan for each person based on their need. Together with education on prevention and treatment, condom lubricant and needle syringe promotion and distribution are main components of community outreach. HIV self-testing kits, where available, also may be included in outreach. Effective condom lubricant and needle syringe programming for key populations requires integration and coordination between outreach and clinical services. It can be supported by regular planning and programmatic monitoring against the targets that are set. A wide mix of service delivery models can be chosen, whether it's static or referral, outreach, on the preference of the community. Peer outreach workers create demand for preventive and curative services and mobilize key populations to visit the program clinic for routine checkups. Regular medical checkups, where a wide range of clinical services are offered, are promoted for all key populations regardless of their HIV status, maintaining confidentiality and building trust. Additional program efforts to promote HIV testing, PrEP, ART work best to boost uptake, adherence, and retention when implemented from a trusted access platform. Promoting checkups rather than specific health services safeguard medical confidentiality and build community trust. Next slide, please. Management for scale and coverage is important for a KP program. Key population programs build on trusted access platforms rely on programmatic data for continuous planning and monitoring progress. This information starts with the most current available estimates of key population location and population sizes. Mapping with population size estimates are very critical, and there are different approaches that are available, including virtual mapping approach, and is an activity at the central level, and it helps in planning for scale and coverage. At the local level, mapping and size estimation guide programmatic efforts. Coordination and mechanisms to manage the response at all levels, starting from implementation level to the national level, is very, very critical. Structures like technical working groups or committee of experts is essential to ensure that the response is coordinated and there is effective communication between all stakeholders involved in the key population program. Key population-led organizations and key population networks play a very important role in ensuring that feedback from the community is communicated to these coordination mechanisms, and action is taken based on suggestion and feedback. Next slide, please. Program monitoring of trusted access platforms measure the extent to which key populations are being reached in the community and using community and facility services. Targets are established using population size estimates as denominators, and progress is reviewed monthly, quarterly, annually. These basic performance data enable reliable monitoring of specific services, including uptake, utilization, and retention. Next slide, please. Quality of service provision determines whether services are used, and it requires continuous community inputs. Community-led monitoring is becoming a very, very critical aspect of strengthening the trusted access platform. Several community qualitative monitoring methods, from peer-mediated feedback to community meetings and community-guided quality monitoring, can be done. Robust routine program monitoring system with core indicators standardized across key population programs help in assessing progress and gaps. Assessment need to be done to also understand whether programs are making a difference in terms of the key outcomes. It could be condom use, needle and syringe use, or the impact on HIV and STI acquisition and transmission among key populations. In addition to routine program monitoring data, we can use survey data, mathematical modeling exercises, and special studies can also be done. Next slide, please. Last but not least, the key population program need community strengthening plans for community and staff members. Staff development requires a capacity building mechanism or technical support mechanism that includes training, supportive supervision based on standards. Community empowerment is a progressive process arising from well-implemented key population programs that can be facilitated by a range of community system strengthening activities. Self-help groups, developing networks of key populations are an example of community system strengthening that empowers key populations to identify specific conditions such as violence or financial vulnerability and takes steps to resolve them. As key population communities become organized, strengthening organizational and institutional capacity is an important component of sustainability. I'll stop here, Clemens, and hand it back to you. Thank you so much.
Thank you so much, Parinita, for this great overview presentation, which really provides the framework for this discussion and is further elaborated in the guidance document that Parinita just mentioned. As the next presentation, we look at an additional element of trusted access platforms, which is virtual interventions, which have become more critical in recent years. And we're very pleased to have with us Purvi Shah, a regional consultant with UNAIDS regional support team in Asia Pacific and also working with WHO headquarters. Over to you, Purvi.
Thank you, Clemens. Am I audible?
Yes. Please
okay. Go. Okay. So good morning, good afternoon, good evening, everyone. This is just a very short presentation on virtual interventions, and I have actually divided the presentation only in 3 slides, and which will differentiate between innovation, implementation, and integration. Next slide, please. So my first slide talks of innovation or innovate, and here I'm actually going to discuss on what kinds of innovations are possible with virtual interventions. When we talk of virtual interventions, there are various things that come to our mind, and a lot of people use different terminologies like digital, online, etc. I think virtual intervention is a mix of everything. It can be mainly internet-based, where countries have high internet penetration and coverage, or it could be phone-based, where the internet coverage is not that great, but we can connect with people over a simple phone call. It also helps us to broaden reach because the kind of population that we're trying to reach online, the key populations that we're trying to reach virtually are a little different from the ones that we find offline because, they don't necessarily identify themselves as key populations. They might not come out in the open and say, I'm gay or I'm a sex worker, but they are equally vulnerable and they do need linkage to services. So virtual interventions actually would allow us to broaden that reach apart from the people that we usually reach through our traditional approaches. Virtual interventions would also give us an opportunity to innovate in a way that we can provide a differentiated service delivery to our populations. It is important to provide a package of or a variety of options to populations that are accessing services. It is important that one particular package of service not be provided to every individual. Every population might have a different requirement, and therefore it needs to be differentiated service delivery. As we know, as we are all struggling with COVID-19, when COVID-19 came in about a couple of years back, most programs were struggling with usual progress in their programmatic work. And I think virtual interventions could be one of the solutions that would help us mitigate the COVID-19 impact on our programs. Virtual interventions actually also helps us to target the reach because we don't need to test everybody. We don't need to keep on providing services to everybody. It helps us to target our reach so that we reach the correct population and so as to improve our efficiency as well as probably make best use of the resources that are available also. There are various approaches that are available for implementation of virtual interventions. It could be virtual outreach, it could be through influencers, and maybe through advertisements as well. This video that you see on the screen right now is an example of an influencer who actually just took a simple video of herself booking an appointment on a platform and then visiting the clinic for getting an HIV test done. Next slide. This next section of implement talks of a probable framework through which you could implement your programs. So this framework has been adapted from the FHI 360's Going Online framework. The top portion of the framework is our basic HIV cascade, which actually says that virtual interventions is not restricted only to prevention or testing. We need to take the population across the entire cascade. So we need to provide them services for prevention, testing, as well as treatment, and on to virtual suppression, viral suppression as well. The lower part of the framework talks of all the approaches that could be used that have been tried out, in fact, in a lot of countries that would help us take the population across the cascade. So there it starts with planning, size estimation, mapping to different outreach approaches and to virtual case management and all the other data related activities as well. Next slide. The third and the most important part is integrate. I think this is very, very important for us as a program where we need to integrate virtual interventions as part of the existing national programs now. It is important that we implement virtual interventions at scale for key populations. As of now, programs are implementing virtual interventions on a project mode or on a pilot mode. It's important that we scale it up and provide that option or that choice to the community, whether they want to access services virtually or they would like to access services physically. Community ownership and leadership will play a very important role in helping us integrate this into the national program. It is also very important to integrate virtual interventions as part of any policies, briefs, guidance documents of any countries. So any kind of national guidelines on testing or national program would benefit if virtual interventions is a part of it, so that countries can use that and start implementing them in their regions and countries. Safety and security measures definitely need to be considered, and it is also important that we integrate virtual interventions into our existing platforms. So it can't work as a silo, it cannot work as a parallel program. We definitely need to integrate it into the existing platforms and the national program also. Next slide, please. Thank you, and I'll be available on this email address for any further questions. I will have to drop off, unfortunately, for other commitments, but please feel free to reach out on this email address. Thank you.
Thank you so much, Purvi, for this excellent overview of different approaches towards virtual interventions. And as you have seen from the detailed diagram that Purvi showed, there's really a whole range of specific approaches which you can explore further. And there's also a document on specific planning and budgeting aspects on our GPC webpage that was developed in collaboration with FHI 360. So further information is available on all those details. From these overview presentations on concepts, we'll now move into specific country examples, hearing from colleagues working in government, hearing from implementers, and hearing from community-led initiatives. So we'll start with the first presentation from Humphrey Ndondo from the NAC in Zimbabwe on Zimbabwe's key population response. Humphrey, over to you.
Thanks, Clemens, and good morning, good afternoon, good evening, colleagues. My name is Humphrey Ndondo. I'll be presenting our Zimbabwe case study on scaling up an HIV program for key populations. Next slide. So as a way of overview, Zimbabwe remains one of the top countries heavily burdened by the HIV, AIDS, and TB epidemics, and we estimate a prevalence of 11.8 within the adult population amongst 15 to 49-year individuals. And we also estimate an incidence of 0.45, which is a decrease from 1.42 in 2011 and 0.98 in 2013. Next slide. So we are observing that despite this decrease in incident and the progress within the HIV response, there are HIV sub-epidemics that show a disproportionate burden of disease amongst key population, with a prevalence of 42.2 amongst female sex workers and a prevalence of 21.1 amongst men who have sex with men, and a prevalence of about 27.5 amongst transgender persons and other non-gender conforming individuals in Zimbabwe. Next slide. So the way the National Key Population Program is designed is that it is particularly collated by the Ministry of Health and Childcare, who oversee the differentiated provision of HIV clinical service delivery, implementing a standard package of HIV interventions to key populations, providing training so that healthcare providers are clinically astute, and also conducting outreach activities using a spoken hub from facilities into the communities using a mobile means. We also have the National AIDS Council, which provide a multi-sectoral response in coordinating policy guidance, community-based prevention, and facilitating and creating and enabling legal and policy environment for the program to flourish. The program is particularly also led by key population communities, and it follows a peer-oriented service delivery system that is strongly led by KP Civil Society. So all these entities work together in unison. Next slide. So to particularly bolster the national HIV response in the past 2 years, we have established a key population technical support committee, which is responsible for coordinating and implementing a comprehensive, a culturally competent national key population program as one technical support committee behind one national HIV strategic plan and using one results framework to monitor the HIV response. This particular technical support committee is co-led by the Ministry of Health and Childcare, as you can see, and also the National AIDS Council. It has leadership, it is then coordinated from within both institutions with a central level secondments and decentralized technical support at subnational level with 5 key population officers. So this is the system that particularly drives the national KP response at this particular moment. And the purpose of the TSC is to work closely with existing public, private, and community structures to scale up the design and implementation of an effective and efficient prevention, treatment, and care programs for key populations. Next slide. So we have developed a model that really follows individuals across the care cascade from the time when we are reaching out to communities in the community, reaching out to KPs in the communities, linking them to a negative cascade when they're HIV naive, and also linking them to care and treatment when they test HIV positive, and following them up with interventions. And we are ensuring that we are following through a cascade and creating an enabling legal and policy environment free of violence, stigma, and discrimination, using data and monitoring to advance and inform our response. Next slide. So what we have seen is really important is that we scale up public sector delivery model to be a viable option for the provision of care and services. And the figures on the left depict are pictures that show in the bottom there is what we have done with geospatial mapping, where we are looking at the extent of coverage and the distribution of service KP-friendly services by partner, where we have safe spaces located in the communities, where we have DICs, where we have clinics, and we particularly ensure that every partners have no overlap, and where there is an unmet need, we redirect resources and institutions or our partners to work at. We are looking at scaling up as we are moving into a new year, scaling up from about 10 facilities to 52 public sector facilities with intense technical support that we provide as a technical support committee. And really we are optimizing access to hotspot mapping exercises that are supported by the national program, trainings, mentoring, coaching in key population friendliness, provision of targeted combination prevention, provision of condoms, lubricants, and PrEP, targeted case finding, differentiated art delivery for KPs, viral load monitoring, engagements of KPs in technical working groups, and so establishing and activating community-led monitoring mechanisms. Next slide. So I'll move very quickly through this. Slide shows us what we are doing with strengthening outreach to improve HIV case finding, and this depicts a safe and ethical ICT. So we are going to be using an eclectic approach of testing modalities, self-testing, ICT, social and sexual network referral testing, PITC. Next slide. We also are differentiating service delivery models, looking at mental health for KP communities. We are also ensuring that we're going to be strengthening our provision of care for trans and gender non-conforming persons through provision of gender-affirming healthcare trainings. We also are going to be particularly strengthening our approach with persons who inject and use drugs within the country. Next slide. This slide particularly speaks to our efforts that we will have, particularly strengthening capacity of KP-led CBOs to deliver HIV, SRI, services. Like we've said, we are going to be using an organizational capacity assessment and training tools that we have developed, and we're rolling these out to ensure that the community response led by KPs is really anchored in KP communities that are strong and are able to particularly offer services and also monitor the HIV responses offered from community, from a community lens. The last two slides particularly speak to strengthening a community-led monitoring, The pictures, as you will see, they depict one of the CLM activities that we have conducted with support from Positive Vibes around lessons learned from community-led monitoring within the Key Population Investment Fund. We want to entrench and strengthen the key populations community leadership in the national CLM structures. We already have established a national CLM steering committee to catalyze key population-oriented monitoring. And we will be harmonizing this across country to ensure that it is community-owned and government-led. This is to strengthen our data systems, our M&E systems, and the evidence required to inform the response. My last slide just flashes the 10 elements that we have learned, the 10 key lessons that we have learned in the implementation of a national KB program. And I will leave this flashed here. Over and thank you.
Thank you so much, Humphrey, for this great presentation showing the great progress that Zimbabwe has made in the past decade, actually, in scaling up key population programs, one of the largest national sex worker programs in the region, and diversifying the key population response to different population. Personally, if I may say, having worked in Zimbabwe until about 10 years ago, I consider this really remarkable achievements that you have reported on here. We have now a presentation from Eastern Europe. Pavlo Smyrnov from the Alliance for Public Health in Ukraine will speak about managing a key population program at scale from a Ukrainian perspective. Over to you, Pavlo.
Hello. Thank you, Clemens. So my presentation will be about Ukraine case in terms of scaling up programs for key populations. Next slide, please. So in Ukraine, we have quite robust key population estimation, which is done regularly every 2 or 3 years. It's not only national figures, but also sub-national level. It all goes through the very long process of validation, triangulation, and then taking a consensus meetings on national and regional level. This is all done because we also have a quite regular IBBS studies and some program data and medical statistics available that can be used for this purpose. IBBS is also used for measuring outcomes of interventions, change in behavior, and to measure HIV incidence in addition to prevalence. This is how we can measure the impact of prevention and testing and treatment interventions. Next slide. But besides these big studies, we also do a regular mapping, which is more a service-oriented mapping and should be done regularly because the situations of key population circumstances, life circumstances are dynamic and venues are changing. So this should be done to make sure that we are covering all the venues with services. And on this map, it's a recent one. You can also notice that there's few locations for people who inject drugs which are not reached by any services, non-existent stationary or mobile outreach. So this is information which was used operationally to move services to these areas. And this can be done even without a big funding for IBBS. It's some simple mapping exercise, which is important on every stage, even if you have very scaled up interventions in your country. The next slide. This is also example how regional MIS data can be used to identify hotspots. Even for key populations, we can use some data from the MIS on pregnant women, for example, to identify some really hot areas where we have, for example, increase in prevalence over the last years, or have high prevalence compared to the average on the region. This might indicate, for example, that there is some outbreak, even among people who inject drugs, because these women could be easily either sex partners or women involved in commercial sex in these areas, and this will somehow indicate the areas where you need to locate your services. Next slide. I just wanted to mention here that we have quite large program which reach about 60 to 70% of people who inject drugs in Ukraine, which is quite a sizable population of about 300,000 people, and some smaller scale for sex workers and MSM. We have been able to successfully transition to government funding from the Global Fund funding in 2019, and you can see that it has not resulted in drop of the coverage, which might be the case, and only there was some drop of coverage for MSM, and this is because there was a number of community organizations which didn't want to participate in the government bidding for services. And this resulted in US subrecipients coming that basically had no access to population, even in this kind of a developed prevention kind of environment. And this might lead to some organizations to complain about estimated population size being too large, but actually it could be that they just don't have access to the population they want to access. And this, of course, requires a lot of efforts to build trust in these groups, and takes time. So all the discussion is very relevant, even to Ukraine, which has a long history of prevention work. Next, so this few slides are something that I would call beyond scale up. So even if you have like 60% of your population covered with prevention programs, you still have room for improvement, and there's few areas you can move either into the unreached risk networks of populations, and this can be done by different technologies like social network strategy. You basically use the recruitment coupons to bring people into the service which have not been yet, and this is something that is happening in like 15 years of quite developed prevention programs in Ukraine. So we still have a lot of people who have never been reached by any service, and as this kind of interventions help us to reach them, test and initiate on treatment, offer some PrEP or a substitution treatment for those who need it. And the next one actually is something that we call mobile social network strategy, and this is combination of kind of scaling up beyond scale up in terms of geographical areas and in terms of going deeper into the unreached risk networks. So for some areas there is basically no either clinical or any prevention or community services available. So, and it's not a huge people there, so we probably will need to invest or this will be quite costly to invest into stationary points or community centers in these areas, but you can solve this easily with the mobile teams, which can combine this mapping exercise, which I showed on the first slides, and identify the areas, even taking data from IBBS, where you can see there is a high proportion of respondents who have never been reached by any of services. And then you can actually, if IBBS recruiters can reach to those people, why cannot the prevention recruiters reach them? So this was our reasoning why we need to move on to these areas with these mobile teams. And they also use this recruitment chain approach to quickly develop the client base and reach as many people as they can in those areas. They offer testing, they offer prevention, they offer also diagnostics immediately, and some of those mobile teams in cooperation with the clinics can offer treatment PrEP, they can also refer people to substitution treatment. And in COVID times, we also use those teams to deliver some of the treatment and other prevention services to the areas which were not reached by any services before. Of course, this is quite hard because they explore the new territories, so they need to find people from the communities there to establish some trustful relationship right away. So it's all this all work is closely done with communities in those areas, and they attract people by actually some active outreach efforts in these places. Next. So in terms of the next two slides, this is something that I wanted to mention in terms of monitoring interpolation. We do use unique code for our key population projects, which actually is now taken by government as well, and used by government the same coding system. So we can actually track the cascade of services, we can see the coverage. We also can do some cross checks with the MIS, because for all positive clients in prevention projects, the same coding is used in MIS system. So we basically use it to validate the number of people who start on treatment, who start on PrEP, and this is really helpful to have this coding system available. Otherwise, it will be really hard to validate your numbers or to see the cascade development. And the last point actually here is also important, because this relates more to structural interventions. We use Reg Database, which allows to record all violations, human rights violations. Mostly it's 70%, it's access to health services, and it allows us not only to record those, but also to react them right away and see what the reason why people have not been able to receive treatment, for example, or testing, or there's some requirements for diagnostics they couldn't match. So this is a very important part of the scale-up efforts, because even if you have services available, having all kind of barriers, system barriers, stigma, violations of human rights, it's really can be a great obstacle to scale up your program. Next slide. We do, because we had this transition 2 years ago, we did a lot of coordination with government in terms of using the same coding system, using the same approach for service delivery. Basically, we have been able actually to get government funding in the same volume as it was in the Global Fund to fund the basic package of services. And right now, with the funding from Global Fund and PEPFAR, we do these additional services, which I mentioned beyond the scale, which is optimized case finding, social network strategy, funding for these mobile teams going out to some areas not yet covered by services. So this is all available right now because we have government supporting the basic package. It's also with this transition, you see some drop off of some subrecipients not willing to participate in government bidding process. So you need to introduce some new partners. You need to train them, or some actually. For some time, you need actually to introduce some direct operations for some complex interventions, which requires a lot of very detailed following the standard operating procedures, like managing recruitment, coupons, managing incentive schemes. So for some time, unless you have a stable partner in this area, you probably need to do some direct operations, which Alliance is doing right now with these mobile teams. And basically, there could be situations where you don't have partners in those areas. Of course, the quality assessment, community monitoring, client feedback, and mystery shoppers is something that we do regularly because, again, we have a change of partners, we have a change of staff, and we really need to, and change of funding as well, switching from donor to government, also have some impact on the quality and some impact on the service delivery. So we need to monitor it closely to make sure the clients are receiving services they should receive and what we pay for. Technical support and supervision should be ongoing. Of course, it's now much easier because we have all kind of virtual training programs and supervision, which is now possible and acceptable by most people because of COVID situation. People are just used to all kind of virtual meetings and trainings. So this can be really reduced cost, done at reduced cost. And again, addressing violence, stigma, as well as addressing other needs beyond testing and treatment, like housing, poverty, food. It's important to scale up programs among some key populations. Thank you very much.
Thank you so much, Pavlo, for this excellent presentation. Looking at scale up, also beyond scale, in going the last mile, if I can say so, and from this really data-driven and implementation perspective, we move to another very interesting perspective on community leadership and ownership in scaling up key population programs, which will be provided by Grace Kamau and Laveria Mwai from Africa Sex Workers Alliance. Over to you.
Good morning, good afternoon, and good evening. I'm stepping in for Grace and Laveria. My name is Charles Mukoma, and I come from Africa Sex Workers Alliance. Before I move on, I want to introduce to you what is ASWA. The African Sex Workers Alliance is a Pan-African alliance of 134 sex workers-led groups that exist to strengthen their voices, to empower and to advocate for the health and human rights of female, male and transgender sex workers, including those living with HIV and using drugs through networking, movement building, and development of partnerships. So ASWA is the one that holds the SWA. SWA means Sex Workers Academy Africa. And SWA means it's a program, it's an initiative that was developed by ASWA. And it's an initiative that is supposed to empower sex workers in terms of using suites to empower sex workers' health and rights. So in 2012, WHO and the UNFPA and Joint United Nations Program on HIV and AIDS and the Global Network of Sex Workers Projects, whom we are a member of, developed a guidance document on prevention and treatment of HIV and other sexually transmitted infections, STIs, for sex workers in low and middle-income countries. So this document, referred to as 2012 recommendations, sets out effective interventions for the prevention and treatment of HIV and other STIs among sex workers. Next slide, please. So these are the guiding principles and approaches. The Sex Workers Academy for Africa is modeled on suites. And the main focus of this tool is prevention and treatment of HIV and other STI infections for sex workers in low and middle income countries, with recommendations for a public health approach. So the training modules focus mainly on, number one, community empowerment. Community empowerment is key for sex workers program because it builds up the capacity of sex workers to be able to come up with their own interventions and to own our programs. Number 2 is addressing violence against sex workers. As you all know that violence is key in terms of reducing HIV infections. And so when violence is addressed, and sex workers are prone to violence because of being criminalized. Sex work is criminalized. And so this leads to sex workers facing a lot of violence, stigma and discrimination. So because of this violence, we see that most sex workers are not able to access HIV services. So once violence is addressed, it reduces HIV infections. The other one is community-led services. We have condom and loops programming, clinical and support services, program management, and organizational capacity building. Next, please. So that's the whole setup of the curriculum. And as you can see, one leads to the other one. And I would like to emphasize on, again, on violence. As ASWA, we are so much concerned with decriminalization of sex work, because we know that decriminalization of sex work would reduce violence in a very big way. A lot of researches have been done to show how repealing of the punitive laws against sex work, how that would improve the health outcomes of sex workers. So we are so much focused on advancing any move that would decriminalize sex work. And then the other one, the last one I want to emphasize on is program management and organizational capacity building. In Africa, most programs that involve sex workers, they exclude actually sex workers in terms of decision making. You find that they don't involve sex workers directly. And so this has affected their programming because they come up with interventions that are not tailor-made for sex workers. And so during the academy, the sex workers are taught on program management, on how to own programs, how to increase their capacity in terms of organizational areas. And we have seen effects of this. We have seen so many new organizations coming up. We have seen great interventions. So, and I'll be talking about that in the next slide. So the next slide, please. All right, so ASWA has conducted its flagship, unique, and one-of-a-kind sex workers academy since 2014. And through SWA, ASWA has reached 429 sex workers from over 33 different countries in Africa, yes. This has led to the formation of 54 sex workers-led organizations by SWA alumni. Additionally, through NSWP, ASWA has provided small grants to 33 countries who participated in SWA to implement their national advocacy plan. So I could emphasize on number 4, once sex workers attend the academy, there is some grant that is set for them to go and implement what they think is best for them. So for example, if it is Kenya, we have like just an example like HOIMAS, which is a male sex workers program. If we have members attending SWA, they are given a small grant to go and implement what they think is workable for them. So we have seen that work out. Then the other one is through the academy, sex workers are trained to advocate for improved quality of services. We have seen success stories in countries like Zimbabwe, where we have Zimbabwe Sex Workers Alliance, Kenya Sex Workers Alliance, Malawi Sex Workers Alliance, and then we have Lady Mermaid Empowerment Center, which started Uganda's first sex worker-led clinic due to the knowledge gained from the academy. We have other startups. These are just a few of them. Next, please. Yeah, so the good practice recommendations is that countries should work towards decriminalization of sex work and elimination of the unjust application of non-criminal laws and regulations against sex workers. And then violence against sex workers is a risk factor for HIV and must be prevented and addressed in partnership with sex workers and sex worker-led organizations. Then we have evidence-based recommendations. Offer a package of interventions to enhance community empowerment amongst sex workers. Next. Yes, so before I finish from the presentations I've had, one of the question or a comment that I would like to leave you with is that in some countries, we have seen sex workers involved very meaningfully. Just to give an example, in Kenya, where we have seen a presentation from the previous presenters, Kenya has involved sex workers very meaningfully, and this is very commendable. But still, we have some other nations, some other countries in Africa where sex workers are not meaningfully involved. So our recommendation is that we should work as a team to see that those countries involve sex workers in their national programming for HIV response. We want to see sex workers involved in strategic frameworks. We want to see them included in strategic plans. We want to see them involved in technical working groups. We want to see them involved in country coordinating mechanisms, PEPFAR fundings, and all those mechanisms, so as we might reduce HIV infections. Thank you so much.
Thank you so much, Charles, for this excellent presentation on the great work that the African Sex Workers Alliance has done in empowering sex workers to strengthen HIV and other health-related and social empowerment programs. Now we've reached the end of the presentation part of this session. We have taken a very special approach this time towards managing the discussion, since we have a specific mechanism to explore commitments to scale up key population programs that you could consider as part of this meeting. So we have posed here one question, that is, in scaling up key population programs in your country, what would you like to improve and commit to? And maybe the presentations have given you some additional ideas, whether it's the overall framework for taking community trusted access platforms that reach beyond one service to scale, as Parinita presented, or perhaps Purvi's elaboration on a really systematic approach towards exploring the potentials of virtual interventions involving key populations, working with key populations, or the great country examples that we've heard in terms of Zimbabwe's scale up of key population programs, Ukraine's approach of further developing a long-standing key population response to go the last mile, or the inspiring words from Charles from the African Sex Worker Alliance. So if from these or from other reflections you have any commitments, what you'd like to improve or commit to, please put them in the Menti chat box. So I think Carrie will post in the chat the link again on which you can click, and there you can actually, with that code, share your countries or your organizations or your personal commitment that you'd consider relevant in terms of scaling up key population responses. Please add your country name in the response or your organizational affiliation. So Carrie has just posted the link. Now, to give you some time to do that during the meeting, I'd suggest that we go straight into a few prepared reflections and questions, We've had good exchanges in the Q&A session, and a number of responses already. We can go into those right after the prepared reflections from colleagues. I'd like to call now on Iurie Climasevschi from the Moldova National HIV Program, the National HIV Coordinator in Moldova, to provide some reflections and commitments to scale up key population programs in Moldova. Over to you, Iurie.
Здравствуйте всем. Не хочется говорить ни добрый вечер, ни доброе утро, потому что такие разные часовые пояса, что и так все правильно. Здравствуйте всем. Я попытаюсь, прошу меня допустить к экрану, да.
Iurie, apologies, we don't have the interpretation. If you'll just wait 1 second. Parinita, are you online?
Hello, I wouldn't like to say good evening or good morning because there are so many different time zones represented here, so I'll just say hello to everyone.
Thank you. I think Iurie could continue, right?
Я не вижу моего экрана почему-то, мне не
Excuse me,
разрешают.
I can't see my screen. There's an issue with...
Just a moment.
Colleagues, just 1 moment.
Сейчас, тут было очень много. Видно сейчас?
Can you see my screen, my presentation now?
Здесь, это очень короткая презентация, но я хотел спросить, если одна видна.
It's a very short presentation. I just want to confirm if it's on the screen, if you can see.
It is visible, yes. Thank you.
Окей.
Yeah.
Во-первых, спасибо за такую представленную возможность. Хочу поблагодарить всех предыдущих коллег, которые представляли такие интересные активности в разных регионах мира. И это показывает, что все то, что делается в области ВИЧ-СПИДа, это делается на всем земном шаре. И это очень радует, потому что это проблема всеобщая, и мы можем ее искоренить только общими усилиями. Значит, первое, что я хочу сказать вот по опыту Молдовы, но я не думаю, что буду говорить что-то очень новое, но даже хочу сказать, что буду как-то и комментировать предыдущие выступления. То есть первое, что мы считаем, что это политический уровень. Если политическая приверженность существует в стране, тогда можно и внедрять разные мероприятия в группах риска, и можно и продвигать разные инициативы. Если этой политической приверженности нет, тогда это очень и очень трудно чего-то достичь.
Iurie, 1 moment, please. I think the translation is not working. So I'm going to suggest, and my apologies for this, that we perhaps try to sort out translation.
Excuse me, it's interpreter from English into Russian speaking. The thing is that simultaneous interpretation is not possible. So we just agreed that I'm going to interpret consecutively, and Iurie will just present parts of his presentation, and then I'm going to interpret that, if that's okay.
Okay, good. So please interrupt then whenever you need to translate, and I'll yeah.
Okay, thank you so much.
Thank you. And we'll have to, given time constraints, we have to be as concise as possible.
Right, okay, then I'll interpret the part that has been said.
Ну хорошо, я постараюсь тогда очень коротко, да. Значит, политический уровень. Затем, после политического уровня, да, мы идем по приоритетам национальной программы. То есть группы риска надо ставить в приоритеты. В нашей национальной программе это группа риска, это МСМ по пользователю неинфекционных наркотиков и группы работники коммерческого секса. Перевод есть, да?
Thank you very much for this possibility to present the situation in Moldova, and I would like to thank all the previous presenters. It was very interesting. My presentation is going to be very short. I'm going to share the experience of Moldova and maybe comment on presentations of previous speakers. So the first very important thing is the political level and the political commitment. If it's there, then we can create different response programs for key populations, and we can launch different initiatives. But if the political commitment is not there, it is very difficult to implement such programs. Secondly, we have to prioritize high-risk populations, and for Moldova, these are MSM, PWID, and commercial sex workers. Thank you.
При планировании бюджета, значит, на меры профилактики расходы должны быть около 40%. Из нашего опыта последние 3 года мы выделили, то есть в программе и так далее, было реально потрачено около 30% из бюджета, общего бюджета, что в принципе близко к рекомендуемым цифрам. Значит, у нас как бы вот только-только начинает набирать обороты финансирование проектов по снижению вреда и работы в группах риска из местных бюджетов. Это муниципальные бюджеты после того, как присоединились к Парижской декларации, начали вот впервые за много лет работы по национальных программ, начали выделять деньги для внедрения местных проектов в группах риска. И последнее из этой группы то, что найден, то есть выработан механизм, который будет финансировать программы снижения вреда из национальной страховой компании, и это как бы переход от международного, от внешнего финансирования к внутреннему финансированию. Да, пожалуйста.
Budget is a very important thing, and it plays a key role for prevention actions. And this budget should amount to 40%. In Moldova, for the last 3 years, we have allocated around 30% for these measures, and this is very close to the recommended amount. Also now we have started financing projects on harm reduction, and this financing is now available also on the municipal level. After we have joined the Paris Declaration, we started also financing municipal projects or subnational projects. And the last thing, now we have also created a mechanism to finance measures on harm reduction as part of our national strategy. So we have a budget on the national level and subnational level.
Значит, программный уровень – это следующая наша такая задача, да, и увеличение охвата или увеличение услуг, не только охвата. Значит, мы берем вместе и как в общем населении группы риска, и в пенитенциарной системе, включая и заместительную терапию метадоном. комплексный пакет для работы с работниками секса и мужчинами, имеющими секс с мужчинами. И пытаться все время внедрять инновации. В нашей стране тестирование под руководством, в сообществе и самотестирование для группы риска с 2018 года доступно на уровне НПО, то есть оно доступно везде, и как в медицинской сфере, так и в немедицинской, в НПО, которые предоставляют услуги в группах риска по снижению вреда. И мобильные услуги по профилактике ВИЧ для групп риска. Обеспечение профилактики ВИЧ через аптеки и, надеемся, в очень скором будущем и вендинг-машинами, учитывая проблемы, которые создает ковид для контакта с людьми и так далее. Пожалуйста.
Also, we have to take into account the programmatic perspective, and the goal here is to enhance the service coverage. And this concerns all key populations, for example, population in prisons. It includes also methadone, OST, it includes MSM and sex workers. And we also try to implement innovations when carrying out these programs. Now we offer testing and self-testing for key populations since 2018 in healthcare institutions. And also we try to create mobile prevention services via pharmacies, for example, but we hope in the very near future also using vending machines, which is very useful in the times of COVID when we try to avoid direct physical contact. Thank you.
Мы накопили очень интересный опыт в предоставлении ПрЕПа. Значит, если в первом году, когда в 2018 году был внедрен ПрЕП, был один получатель, то есть два получателя ПрЕП, то в следующие годы было уже, учитывая, что мы сделали его коммунитарным ПрЕПом, то есть его предоставляли не только в медицинском учреждении, но и в НПО, который работает с группами риска, то получилось, что мы за год, за два дошли до 250 человек, увеличили охват. Конечно, это не очень много, но у нас и страна маленькая, и так много желающих. Но если взять в динамике, то, используя коммунитарный ПрЕП, то мы достигли очень хороших результатов. Значит, дальше сосредоточение на непрерывности работы с группами риска и очень важно на гендерные чувствительные вмешательства. То есть все, что мы делаем, мы все время используем и вот эти гендерные чувствительные вмешательства.
Thank you so much. I think we will have, unfortunately, after this translation, to move to the next speaker because the translation is taking long. So over to you for translation, and then we'll.
We have very good results in the sphere of PrEP. In 2014, for example, there were only 2 persons that were covered by such programs, but now the coverage has been increased to 250 persons. It's still not a big number, but Moldova is a small country, so that's a good result for us. And we also provide these services on the community level. The dynamic here is very good. We also try to ensure continuity of such efforts with key populations, and we apply the lens of gender issues when providing continuity of PrEP services for key populations. Thank you.
Benedikt, 1 minute.
Thank you so much. Thank you so much for your contribution. Thanks. I think we'll have to move to the other speakers because we have only 10 minutes left and we still have three contributors.
Последний слайд, да.
Thank you so much.
Да.
So thanks for this experience from Moldova, which was also great to hear. Susie McLean from the Global Fund will give us a perspective on Global Fund support to key population responses and scaled programs, in particular community access platforms. Susie, over to you.
Thanks, Clemens, and hello, everybody. I just wanted to make a few comments. I started to write them, actually, recognizing that we've got limited time available, but let me just say a few things and just have a bit of time for others. The first thing I just wanted to emphasize is how much the Global Fund is emphasizing the need to get to a larger scale for KP prevention programs. I should say by introduction, I'm an HIV prevention advisor at the Global Fund. And so the Trusted Access Platform guidance and concepts are really important for us, and we can see them applied in a whole lot of different ways in different countries with different grants that we're investing in. And also too, we can see in other countries the need for some of these concepts to be set out more clearly as we try to improve and scale up our investment in KP prevention. And so yeah, we find the guidance very important and helpful, and we kind of urge stakeholders in KP stakeholders in different countries to be using this guidance as they're thinking about larger scale KP prevention programs. And so I just wanted to emphasize how important this is for the Global Fund. I also wanted to emphasize how, as we develop the new Global Fund strategy, that we're really emphasizing HIV prevention. We're emphasizing the need for larger scale HIV prevention programs for key populations. And we kind of wanted to kind of emphasize a point that I'm sure will be clear to many of you. And I feel like it's implied, and a concern with this is implied in many of the presentations that we've heard today, which is this thing about need to get to greater reach, greater scale, greater coverage, that from a Global Fund perspective, the coverage gaps are still too large and still too untenable, and that that we're looking for ways to invest that that bring greater innovation or new platforms for service delivery or whatever, in order to be closing those coverage gaps. So closing coverage gaps for key populations, you will see as being a strong focus in the new Global Fund strategy. So, for example, things that we've heard from today from Zimbabwe and Ukraine, for example, about innovations to reach larger numbers of people, or innovations to reach those not already reached by KP programs, really important for us all. And let me say, important for the Global Fund. This is the kinds of stuff that as national programs plan their KP programs, we really want to invest in. The other thing I just wanted to, the other final comment that I wanted to emphasize here is something that's really not been a focus of a lot of our discussions today, and not been a strong focus in some of the presentations, that I'm hoping maybe the next time or something we can bring more attention to, and that is the work on the right-hand side of the screen, if you like, the work that's about prevention-related outcomes. So I find in a lot of these discussions that we have so much excellent attention to the kind of inputs, to the way programs are crafted, to the important considerations as KP programs are defined and packages are defined, etc. All really important work. Don't want to take away from that. But it would be great to be talking about those input issues, how programs are defined, what the elements of the package are, what the approaches to reach and scale are. But in terms of the kind of outcomes that we can see in places like Ukraine, you know, really large, high coverage programs amongst people who inject drugs, but also, from what I understand, some really impressive results around things like the numbers of injectors who are using clean injecting equipment, or the numbers of people who are reporting consistent condom use. So it'd be really great, I think, when we think through these trusted access platform issues together, to be together getting clearer and clearer about what some of the prevention outcomes are from this large scale work. I'm going to stop talking now, but yeah, just to kind of emphasize that large-scale KP programs have always been a priority for the Global Fund. They will continue to be, or our interest will expand, if you like, in that, and that we really value places to dialogue about larger-scale KP programs such as this and guidance such as the Trusted Access Platform. Thanks, everybody.
Thanks so much, Susie, and really important points on prevention outcomes, and I think that's probably a good subject for subsequent discussions as well, and different results that we have. And I'll hand over now directly to Tisha Wheeler from PEPFAR, who will provide a perspective on key population responses and scaled access platforms from PEPFAR perspective.
Thank you, Clemens. I see we're about at time, so I'll just shorten my remarks. What I wanted to highlight for everyone here is that in the key populations and programs in PEPFAR, we are changing our COP guidance. That's, our COP or our ROP annual planning guidance for key populations is changing. We are modifying it now based on many of the things we've been hearing from civil society out of the learnings from the KPIF, out of the listening sessions from the PEPFAR strategy, and out of meetings like this. So I would like it very much if we can hear from civil society at the time of the COP guidance revision, which should happen in about a month. So the COP guidelines will be posted for public review and comment. And, we can gain even more from your comments. And, we try to be the best advocates we can of key populations programs within PEPFAR, but I think being open and transparent from our side and sharing this guidance with you and hearing more from your side is just, it doubles the efforts to focus on key populations appropriately and to ensure that civil society's voice is heard. So please take that opportunity to review the new guidance that we're drafting right now, feed into that guidance, and as much as possible, I can tell you we've tried to respond to what we've been hearing from civil society, our KP-led and KP-competent partners, and the great epidemiologists and scientists out there, who are part of these efforts. With that, I'll turn it back to you, Clemens. Thank you.
Thank you so much, Tisha. Great remarks and really a wonderful invitation to contribute to COP guidance. We'll go from Tisha to Judy Chang from INPUD. And Judy, you have the last word. Don't feel constrained by time. We still have a few minutes. We have not lost participants in the last few minutes. So I think there's still interest. And you have the last word in terms of reflections and commitments to scale up key population programs.
Thanks, Clemens. So yes, just in terms of scale up of key population programs, of course, as we've discussed here, we know what is important are strong health infrastructures, logistics, human resources, and financial inputs. But in tandem, what we really need, especially as communities, is real tangible commitments and action and plans on removing the structural barriers, particularly criminalization, violence, and stigma discrimination. And we know that these are absolutely key to programmatic success and scale up. And of course, people at the center, putting people at the center as well, that is key populations themselves. So I think I'm getting used to the new terminology, trusted access platform. So, from my perspective, it's a place where, and what should, be front loaded and what is key, and the underlying principles of that is, creating a space and a place where key populations feel welcome, that, make sure that they're attracting people through the door and keeping people engaged, and that it goes beyond, you know, what is acceptable or feasible, but is really about the optimal matching of needs, schedules and preferences. And that, you know, goes from commodities to finding the right delivery platforms, and of course, rights affirming environments. And this will not happen, as I think has been mentioned by people before as well, this will not happen without having communities meaningfully involved from design, implementation, monitoring, and evaluation. But we do know that there are the criminal and punitive laws and policies that not only block and prevent engagement in services, but they also, you know, very importantly, limit and constrain movement building and sustained leadership amongst our communities. I think, you know, we also see the ways that legal and policy environments create attitudes that impact on health systems. And we know that health is not a neutral space for key populations. We know that not only is there widespread stigma and discrimination, but there are punitive practices within health services themselves. So for example, you know, within harm reduction programs, many people who use drugs are punished within services by having their take-home doses of OST revoked, or can be expelled from programs if they don't conform to inflexible rules and regulations such as abstinence. Of course, there are many examples of really good key population programs, especially when delivered by key populations themselves, that offer more than commodities, but really offer non-judgmental and person-centered services that really work to adapt and accord with people's needs. So this means where people are not treated as just a number statistic, but are recognized as whole people with complex needs. You know, for example, a harm reduction service that is run by people who use drugs in Kyrgyzstan, RENA, they not only provide harm reduction services and commodities, but they help clients get legal identification documents so they can also access social protection measures. So I think I just also want to emphasize, you know, as we're talking about scale up and wider coverage, a concern is that, you know, that we lose that quality, that decentralization and person-centered care, and, you know, that should really not be diminished as we're talking about scale up. And, you know, we need to think about how to, you know, maintain quality. Of course, there are many examples of excellent programming that are featured in the key population implementation tools. That's the IDoIT, SWIT, Transit, and MISMIT. And really think that these are important guides for getting us closer to the targets, the Global AIDS Strategy targets on community leadership, decriminalization, and stigma and discrimination. Thanks.
Thank you so much, Judy, for these excellent reflections. We have actually reached nearly the end of this webinar, and we'll have most of the closing remarks and reflections, because we want to take one moment to look at the inputs that were actually made in the Mentis interactive tool that we've shared, and I'll call on Carrie to actually share it. So we have a number of reflections there on what people were actually in the morning and in the afternoon, where we had virtually the same webinar made, and a lot relates to capacity development and community-led initiatives. I don't know, Carrie, if you'd like to highlight a few more, just in 1 minute or less than 1 minute. Over to you.
Thank you very much, Clemens, and thank you very much to the colleagues for all the submissions in the Mentimeter. We'll circulate these. I think just to emphasize many of the points that have been made previously, I think throughout the comments, what really stands out are the importance of political and financial commitment, the importance of capacitating and supporting financially, as well community-based organizations and KP-led organizations. Certainly community-led monitoring is something that there's been a lot of interest in, and a key theme that has come up through this Mentimeter. And I think just generally a recognition that an appreciation for providing a platform such as this to see real examples and practical examples of how KP programs are being scaled up and integrated into government programs and spaces. So I think there's a lot more, Clemens, and I'll happily share this, but those are some of the key things which have come up. Thank you.
Thank you so much, Carrie, and thanks to everybody who has contributed such rich suggestions as part of this community of practice discussion. As mentioned at the beginning, this is not the end. We've just started. We'll have additional sessions that will also be very practical on structural interventions, monitoring and evaluation of key population responses, and financing, which is a critical question. And we see it coming out also here in your suggestions as well, that this issue of increasing domestic and international financing for key population responses is essential in many countries. So to sum it up really in just a few words, I think we've heard a lot of suggestions on how we can go beyond individual services, just providing testing or condoms or individual elements, towards establishing scaled platforms and including face-to-face traditional approaches that have been used for a long time but often not scaled, to introducing new and in some cases alternative approaches such as virtual elements that can also be community-led and can complement traditional peer-led outreach. We've had one question that striking in these conversations, that was what to do if there are no key population-led organizations. What if we just have one maybe donor-funded project? Is that really feasible? And we believe that in most countries at one stage, even in the most successful cases, this was the situation where programs started. And what it really took is bringing government implementers, communities together around one table, develop a vision for a joint program, and then see what are the functions that the different constituencies can play in working together to build a scaled key population program. And we see a lot of services that governments, that civil society provides, whether that's health services or education services, as a norm that they exist in every community, in every district. And I think our thinking can shift here to also say health services, social support for most vulnerable populations, HIV prevention services for key populations should also be part of this norm of providing scaled services and outreach where people need it. And with that, just one last practical suggestion. We have a Global Prevention Coalition website where you will find the key population implementation tools, the trusted access platform document, virtual interventions guidance, and also a whole set of country documents, including the complete set of documentation of the Kenya program that is available there, where a lot of the standard operating procedures, M&E forms, training manuals for peer outreach are available for you to look through, and perhaps one or the other element could be interesting for replication in other countries or adaptation to other country contexts. With that, I'd just like to thank the team at the South to South Learning Network. They have been great in supporting the logistics of this meeting, and we'd really like to recognize them and all partners who have been supporting this. Most importantly, also key population communities who have been contributing to this webinar. So thank you with that, and we look forward to re-engaging in the next session of the Global Community of Practice. We'll reach out to you with an invitation and look forward to your participation. Thanks so much. Have a great day or great evening wherever you are.